Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Today I want to talk a little bit about Nandrolone. I had a request from one of my subscribers to talk about three different things that are being commonly prescribed in a lot of these TRT and men's health clinics. One being Nandrolone, the other being oxandrolone, and then of course peptides. Rather than just give you something superficial and combine all three of those, I thought what I'd do is break this up into a series. And because Nandrolone is probably the most popular and is becoming increasingly more common in terms of what's being prescribed at these clinics, I thought I would just tackle that one today, and we'll do a bit of a deep dive on Nandrolone, and we'll go over the pros and cons. We'll talk a little bit about how it works, and I think I'm going to give you guys some information today that I bet you haven't heard before, and I'm going to go out on a limb and say that your doctor probably may not be aware of or may not have shared with you prior to prescribing Nandrolone to you in the clinic. So, and then at the end, I'm going to talk about my personal experience with Nandrolone, because I have been on Nandrolone now for just over 12 weeks, and I'm going to share my experiences with you and let you know from a first-hand standpoint how things are going for me. Okay, so let's get into it here. So what is Nandrolone? Nandrolone is very similar chemically to testosterone, and as you can see here, here's the chemical structure of testosterone, and the only difference with Nandrolone is that at the C19 position here, this little methyl group has been chemically removed. And you wouldn't think that that's a big deal, but in steroid chemistry, when you start monkeying around and changing some of these methyl and ethyl groups and hydroxyl groups, rearranging them, it can have some pretty profound effects in terms of how that particular molecule works. So Nandrolone was synthesized, and I believe it came into the market like around 1960. They were looking to create a anabolic substance similar to testosterone that had a lower degree of androgen effects, or lower androgenicity, or perhaps you could say like a higher anabolic to androgenic ratio, and then use that in a number of different clinical situations to treat various conditions. And so it's been around for quite some time. There's a lot of data on Nandrolone, and not surprisingly, the bodybuilding community got a hold of Nandrolone not long after it hit the market. It was very popular in Arnold's day back in the 70s and 80s, and as far as I can tell, it still gets pretty heavy use in the bodybuilding community. It's not used as much in the athletic world anymore, because it's very easy to pick up on a drug test, and even for months and months and months after you've stopped taking it. Apparently there's some very long-acting metabolites to it, so you're not going to catch a lot of Olympic athletes using Nandrolone, at least as far as I know. So changing that little methyl group does a number of things to that molecule that make it different than testosterone. So one of the big ones is that, as you all know, testosterone binds to sex hormone binding globulin with very high affinity. But Nandrolone, taking that methyl group away, it has a very low affinity for SHBG. So maybe like 5% of the binding capacity or binding affinity as compared to testosterone. The other thing is it doesn't aromatize into estradiol anywhere near as much as testosterone does. It does in a tiny, to a very small amount, but it's virtually zero. You have to take very, very high doses of Nandrolone in order to get a detectable estradiol level, as a result of that. And then the way that it loses, or the way it has less androgen effects, is that the 5-alpha reductase enzyme does not convert it into DHT, which is what happens with testosterone. It gets converted into something else called dihydronandrolone, which is far less androgenic than DHT. So whoever came up with this particular compound was successful. They created a compound that retained many of the anabolic tissue building properties of testosterone, but had significantly less androgen effect, as compared to testosterone. So the one thing that nandrolone does, however, is, nandrolone is in many ways, it's a progestin. So it does bind to the progesterone receptor, although not with high affinity, obviously, as compared to progesterone. What I saw is it binds about like 1/20th, the strength. But again, if you're a bodybuilder and you're taking massive doses of nandrolone, there may be a significant progesterone effect, and it's thought that that might be part of the reason why bodybuilders and other athletes, gym bros, taking big doses of Deca, in addition to maybe testosterone or other aromatizing androgens, they can still develop gynecomastia because there's some synergy between the progesterone effect and the estradiol that's coming from the other drugs that they're taking. And if they happen to be genetically prone to gynecomastia, that can be an issue. So it's a bit of a myth that you can take nandrolone and not develop gynecomastia, in particular if you're using it with other androgens that tend to aromatize. Most commonly, it comes in this decanoate ester, and as you guys know from some of my other videos, the type of ester that is attached to this particular steroid molecule largely dictates what its half-life is going to be. So this is just a pharmacokinetic curve here of nandrolone. This is what happens after 200 milligrams injected intramuscularly. You can see a nice big peak, as you would expect, and then you get this slow decline here. Generally by day 14, 15, 16, you're approaching what your prior baseline was. So a little bit longer looking curve than, say, testosterone cypionate or enanthate. So that's why Deca or nandrolone is typically dosed like once a week, although you can certainly do it twice a week. And that seems to be actually one of the more common protocols that I see these clinics doing, is twice a week dosing. But because of the decanoate ester, you can get away with doing it once a week, which is what I've been doing. Okay, so what are the, obviously these clinics are using nandrolone off-label, and we'll talk a little bit more about that, but there are some legitimate and long-standing uses for nandrolone. It just doesn't get used as much as perhaps it did in the past, even though there's a good literature base for it, and I think you can make a case in many of these conditions that nandrolone is actually as good as or superior to some of the newer medications that are on the market. So it's all the stuff that you would expect, right? So treatment of like advanced cachexia, HIV wasting, treating severe muscle and tissue wasting after severe burns, adjunct therapy with certain forms of anemia, such as chronic kidney disease. There's actually a lot of studies on that. People that lose kidney function and end up on dialysis almost always develop a severe chronic anemia, and typically that's treated with like EPO shots and a number of other different treatment modalities. But androgens work just fine, and they're dirt cheap, and there are plenty of studies out there showing that nandrolone can be effective for patients that suffer from chronic kidney disease. It's just one of those things that's kind of been forgotten, even though it's been around quite a long time. The interesting thing about nandrolone is, we think of it as a synthetic and an artificial androgen, and largely it is, but your body does make microscopic, minuscule amounts of nandrolone naturally, and it's one of the byproducts of the aromatization of testosterone. And so it's actually, you can get detectable levels of this if you really look for it, especially in pregnant women, but this happens in men too. And if you're curious, like, these are the chemical steps. Testosterone gets converted into all these intermediaries, and then finally is transformed into estradiol. But a little byproduct of that is you get a little squirt of nandrolone there at the end. So it is technically a natural hormone. What are its uses in men's health? So let's talk about that a little bit. So most of what I'm going to share with you comes from this article here. It's a review article. It's called Beyond Testosterone Cypionate: Evidence Behind the Use of Nandrolone in Male Health and Wellness. It is from the 2016 issue of Translational Andrology and Urology. It's a pretty good article, and it makes the case that in certain circumstances, men suffering from hypogonadism could potentially be treated with nandrolone and receive clinical benefit from that. I'm going to say that their case is kind of weak, in my opinion. But they do mention some specific examples, and you can probably guess what they are. But nandrolone is still it still retains much of the anabolic properties of testosterone, but obviously with the fact that it does not convert into DHT. If you have a man who's particularly sensitive to the androgenic effects of testosterone, so they use the example of men with androgenic alopecia who are just terrified about losing their hair. You could potentially use nandrolone to slow the rate of hair loss in men that are prone to that condition. They mention also that men with BPH, prostatic hypertrophy, could benefit from nandrolone instead of testosterone due to the effects of DHT on the prostate. That's, we know that that's actually a myth at this point. So that particular use case does not hold water for me. And then the other thing that they mentioned, and technically this is true, men who have very high SHBG levels, and that are not coming down with testosterone therapy, you could potentially mix in nandrolone into their protocol with testosterone and, allow them to get some clinical benefit from that. Because again, like as I mentioned, it just doesn't bind to SHBG anywhere near like testosterone does. But, in general, I wasn't really super impressed with their argument for using nandrolone certainly as monotherapy for hypogonadism. I think in general that's a bad idea, and I'll maybe talk about that a little bit more here coming up. This is the big one, and this is a fascinating article, and I was glad to find this because the gym bros and bodybuilders have known about the beneficial effects on joint pain, arthralgias, myalgias that nandrolone delivers. They've known about this since the 60s and 70s. You hear bodybuilders talk about it all the time. They get on a cycle of nandrolone, and all of a sudden their chronic shoulder pain, their neck pain and back pain, all of it just either goes away completely or gets markedly better. So there's been a lot of anecdotal evidence about this, but this particular study looked directly at the effects of nandrolone on joint pain and pain scores in men with low testosterone. So this is from Translational Andrology and Urology. Nandrolone decanoate relieves joint pain in hypogonadal men, a novel prospective pilot study and review of the literature. So in this particular study, what they did is they took men, they had confirmed hypogonadism. These men, they were all using somewhere around either 200 milligrams a week or less of testosterone. What they did is they kept them on their testosterone dose and then added in half of whatever their testosterone dose was. They added in nandrolone to that. So, for example, if you're on 200 milligrams a week of testosterone cypionate, you would stay on that, and then they would add in 100 milligrams of nandrolone onto that. So you'd have both of those substances running at the same time. Average age was 46. They used 48 men. Average duration was 62 days. And then the average nandrolone dose, they said, was 110 milligrams per week. So, reasonably low dose, at least by bodybuilding standards. We'll cut to the chase here. 72.2% reported marked improvement in joint pain, and 27.8% reported a decreased need for long-standing pain medication. So that's fairly impressive. Amongst responding patients, pain scores were reduced by an average of 52%. So, what is the pain score that they used? So this is the rheumatoid arthritis pain score. It has 4 components to it. It's a way to measure chronic pain, and it was invented in the rheumatology world, but you can apply this obviously to other sources of pain. And so the four metrics they look at to measure chronic pain are the physiologic, the affective, sensory discriminative, and cognitive, and then they bundle those together and they give you a total score. And this chart says it all right here. In every single one of these different areas, nandrolone showed significant improvements, and then you can look at the total score at the end. They're markedly improved, right, with nandrolone. And this is important. Any of you guys that have suffered from chronic pain, chronic pain is not just a sensory experience. It affects you emotionally. It affects you cognitively. It can change your personality over time. So dealing with, chronic pain is a major issue in this country. It is, it's not something that we treat very well, from a medical standpoint. Many of the drugs that we use are dangerous. They're addictive. They come with a host of different side effects. So if there's anything out there that can get people off of these chronic pain medications, I'm certainly interested in hearing about it and interested in knowing about it. And this particular study, it was showed some pretty impressive overall results with, again, an average pain score reduction of like 52%. So that is likely to translate into a major quality of life improvement for these men who are dealing with chronic pain. Okay, so what are the cons? We're going to take a bit of a deep dive into this. Now, the one that you hear about all the time is erectile dysfunction, and they call it Deca, right? And that comes from the bodybuilding world. It's a bit of a myth. It certainly occurs. It certainly can occur in high doses and definitely with monotherapy. And I think the reasons for it are fairly obvious. DHT is required to maintain proper sexual function. Well, if you're on Nandrolone, you're going to get very low levels of DHT, right? Because it doesn't get converted to DHT. You also need healthy doses of estradiol in your system. And again, if your axis is shut down and you're on high doses of Nandrolone as monotherapy, your estradiol levels are going to be markedly suppressed as well. So without those two, it's no surprise that you're going to suffer from erectile dysfunction. It's a bit of a myth that there is a persistent myth out there that Deca raises prolactin levels. And it's really not true. You hear that it caused that. When I looked to go see actual studies, all the studies that I could find showed no elevation in prolactin. So I think that's a bit of a myth that's just been kind of circulating out there in the bro world. So, Deca is not necessarily related to higher prolactin levels, but is much more likely to be related to suboptimal DHT and estradiol levels. So, that is not something that you can expect to encounter if you are taking this with testosterone, which is how these clinics are prescribing it. So I don't think that you necessarily have to worry about developing ED unless you already had it, prior to starting Deca. Now we're going to get into some of the more interesting stuff in terms of the cardiac effects, and this is something I'm particularly interested in. I want to give you guys a few caveats before we get into these studies. So most of the studies out there looking at the effects of Nandrolone on cardiac tissue are done in animals. And they're done in animals, and they're done with extraordinarily high doses. So doses that sometimes even in the bodybuilding world are in excess of what many of these professional bodybuilders are using. So you'll see commonly in many of these rat studies, they'll give them like 2 milligrams per kilogram. So, that translates, if you're a 100 kilogram man, you can do the math. I mean, that's 1,000 milligrams of Nandrolone a week, which is an ungodly high dose. Typically in the bodybuilding world, most guys out there use, 200 to maybe 600 milligrams of Nandrolone, on the high end. So, 1,000, I'm sure there's guys out there that do that, but that's a lot of Nandrolone. And, so it's very difficult to translate that into what is being prescribed in these clinics, which is typically like a total of between 50 and 100 milligrams a week. In medicine, it's always the dose makes the poison, right? So it's hard to say whether there's, whether those effects would be seen at the much lower dose. The other problem with many of these studies is that they're relatively short duration. You can't keep people, especially you can't keep human beings on Nandrolone for 5 years at those kind of doses and study them. It wouldn't be ethical. No IRB would allow that. So it's difficult to know how the literature that's out there right now translates into what is being prescribed in these clinics. But having said that, I think we still can make some assumptions. And I think that if you are somebody who's been prescribed Nandrolone, that you at least need to be made aware of this. And I'm almost certain that when most physicians go over and they talk about before prescribing a medicine, you should always discuss risks, benefits, and alternatives, right? Before you prescribe any medication, before you do any sort of intervention, surgical procedure, etc., you have to talk about risks, benefits, and alternatives. And the guys that I know that have been prescribed nandrolone by some of these TRT windmill clinics had no idea about any of the stuff that I'm about to tell you guys. So let's review. This is just one of the few studies out there that at least they looked at human beings. The problem with this study is that it just wasn't done for very long. But they did use humans, and they used at least a much more reasonable dose. So this is from Clinical Endocrinology, 2007, Effects of Testosterone and Nandrolone on Cardiac Function, a randomized placebo-controlled study. So they took a group of healthy young men, and they gave them 200 milligrams of testosterone a week, and then also 200 milligrams of nandrolone. So again, higher than these clinics are prescribing. Many of them do prescribe 200 milligrams a week of testosterone, but 200 milligrams of nandrolone, at least from what I'm seeing out there, from what I'm hearing as feedback from you guys, is a bit high for what is currently being prescribed. So, but at least it's not the 10 milligrams per kilo that they're giving to the poor rats. So they put this group of relatively healthy young men on 200 milligrams of testosterone, 200 milligrams of nandrolone. They did it for 4 weeks, and then they did a whole bunch of comprehensive cardiac tests, including transthoracic echocardiograms to look at was there ventricular remodeling, were there any hemodynamic changes, were there changes in blood pressure, that sort of thing. And at least in this study with 200 milligrams of nandrolone, the conclusion here, 4 weeks of treatment with testosterone and nandrolone had no effect or adverse effects compared with placebo on cardiac function in healthy young men. Okay, again, major limitations to this study. I would be very curious to see what this would look like if they went out 16 weeks, 20 weeks, a year, that sort of thing. I have a feeling that the placebo group and the intervention group would start to diverge there, but we'll talk about that here in a second. Now this next study, this gets a little bit concerning to me. Now again, this is an animal study. It's from Toxicological Sciences in July 2007. Nandrolone potentiates arrhythmogenic effects of cardiac ischemia in the rat. So they gave these rats an ungodly huge dose intravenously, by the way, of nandrolone, and then they poor rats. They tied off their left anterior descending artery, major artery, that sends blood to the left ventricle, and they basically induced a heart attack. So they cut off blood flow through the LAD, and then they looked and saw for a set period of time. They induced ischemia, and then they saw what happened. And long story short, the nandrolone itself didn't do anything, at least acutely. But once they tied off the artery and they induced ischemia, essentially simulating a heart attack, what they found was that the rats that had received nandrolone, their survival rates plummeted. They had much higher rates of ventricular tachycardia, ventricular fibrillation, both of which can be lethal arrhythmias, and they did not do well at all compared to the control group, which received placebo. So that's a bit concerning. And you could translate that into if a man suffers has a significant atherosclerotic plaque in the LAD and is taking high doses of nandrolone, potentially that man's the odds of survival for that man have dropped off significantly from the nandrolone. And in this study, this is interesting. They say the underlying mechanism is currently unclear, and this is a 2007 study. But what's interesting is that they actually did figure out the mechanism, and that's what I'm going to show you here. This is from a 2010 article, so 3 years later, Journal of Molecular and Cellular Cardiology. This is fascinating. So chronic treatment with anabolic steroids induces ventricular repolarization disturbances, cellular, ionic, and molecular mechanisms. So they not only looked at the structural effects of nandrolone on the heart in terms of valve functions and thickening of the ventricles, etc., but they did muscle biopsies and they looked at the ion channels and they measured the electrical activity of the heart, which the heart is an electrical organ, obviously, and they found some major effects from nandrolone. And again, massive doses, 10 milligrams per kilogram. So again, I'm over 100 kilograms, so for me this would be like over 1,000 milligrams of nandrolone a week, which is like a mind-boggling amount of of nandrolone. But with that in mind, what they found was that it markedly changed the ability of the heart muscle cells to repolarize. So in order for a heart, cardiac muscle cell to contract, it has to receive a signal. It depolarizes, meaning these ion channels open up, sodium comes in, potassium comes out. You develop what's called an action potential that leads to the release of calcium, inside the muscle cell, which leads to contraction, and then it relaxes, it resets, so repolarizes, and then it happens, the cycle continues, okay? It's a gross oversimplification, okay? So this is what a cardiac action potential looks like here. We have the left ventricle and the right ventricle. Interestingly enough, the effects of nandrolone were much more profound in the left ventricle than in the right. The left ventricle is much thicker. It's what's responsible for pumping blood systemically. So all of the tissues in your body. The right ventricle just transports blood, pumps it up through the lungs where it can pick up oxygen, comes around, goes to the left ventricle, and then off it goes, brain, kidneys, etc. So you can see here that there was an effect in the right ventricle as well. But look at this with the left ventricle. They have this little arrow, Deca. So instead of this nice quick downward slope, which is what you want your heart to repolarize quickly, to get reset so that cell can contract again. When nandrolone was there, it slowed this action potential down. All right, and it did that by impeding and reducing the number of potassium channels that were present in the cardiac myocyte by up to 40%. So that's particularly concerning because that's led to something called a prolonged QTC, or prolonged QT interval. This is something I see quite commonly in the emergency room, and it's very common. There are people that have this congenitally. You'll see it sometimes with major electrolyte disturbances. Low magnesium, is one that I see quite a bit. And there is a whole host of medications that make your QT interval prolonged, or can. Everything from antipsychotic drugs, obviously different like cardiac medications, even common antibiotics. And so there are people walking around with prolonged QT intervals that have no idea that they have it. And if they get put on, 2 or 3 different drugs that also prolong the QT interval, those are the people that are at risk for sudden death from a cardiac arrhythmia. And so that's a bit scary. So this is a chart here showing over the course of 8 weeks what happened to the QT intervals of these rats. So the open squares are the placebo group, and then as you can see, like from week 1, as they went forward, all these little triangles here, the QT interval just went up and up and up. It seemed to plateau, sometime around 6 weeks. So markedly different. According to the article here, they said nandrolone abnormally affects ion balance in several ways, including altering calcium mobilization and downregulation of potassium channels, causing longer QT repolarization time. So the danger with a prolonged QT is that you can get this what's called an R on T phenomenon. And I'm going to show you what that looks like here in a second. But essentially it's from an extra beat, like a PVC, preventricular contraction, that comes at just the wrong time. And it's superimposed on the repolarization, or the T wave, from the last cardiac beat. And so what that looks like is, so this is an EKG here. Everything's going great. It's a 12-lead EKG. Everything is going great. And then we'll look at, you can look at the bottom one. There's this last beat here, which is a bit abnormal. That's the PVC. Okay, so it's an R wave on the preceding T wave that happened just at the wrong time. And look, it triggered this very abnormal looking rhythm here. This is called polymorphic ventricular tachycardia. This is a lethal, potentially lethal arrhythmia, and extraordinarily dangerous. I'm gonna speculate a little bit here, and some of you guys may have heard about, this is a number of years ago, Rich Piana was a famous bodybuilder, famous like personality in the bodybuilding world. And again, this is pure speculation on my part, so not meant to disparage Rich, or to bring any additional pain and suffering to his family. May he rest in peace. But allegedly what happened with him, clearly he was very open about his anabolic steroid use. I don't know how much, if any, nandrolone he was using at the time of his death, or if what his history with that particular medication was. But it's probably safe to say that his body had seen some nandrolone at some point in his bodybuilding career. I don't know that for sure, but I think it's likely. So, and quite frankly, given some of the dosages that he's talked about before, he probably had been using high doses of that. So again, this is pure speculation on my part. I don't know, but allegedly what happened was that he may have snorted some pre-workout and then collapsed at home, had a cardiac arrest, and unfortunately by the time he could be restored back into sinus rhythm, before he could get return of spontaneous circulation, he suffered a severe anoxic brain injury, and sadly he ultimately passed away. But it's not inconceivable that the acute use of a potent stimulant like a pre-workout, like cocaine, which again he was not involved in this case, but cocaine, methamphetamines, high doses of caffeine or other things that maybe are in pre-workouts. If you have somebody who's got a pre-existing prolonged QT interval, I know when I take a little bit too much caffeine, I do get palpitations and I get PVCs. So, it's possible that snorting pre-workout, if Rich had a prolonged QT, he might have suffered this R on T phenomenon, which caused him to go into this polymorphic ventricular tachycardia, which ultimately led to his death. Again, pure speculation on my part, but this is kind of a hypothetical scenario of what could potentially happen and why this is so dangerous. So we do know from his autopsy, he actually, to my surprise, actually did not have a significant amount of atherosclerotic plaque. He had, a bit in his aorta, minimal amounts in most of his coronary arteries. So, he didn't die from plaque rupture. He didn't go into a lethal cardiac arrhythmia due, presumably, to ischemia. Although vasospasm could have played a role in this, but we do know that he had a markedly enlarged and hypertrophic heart. His autopsy showed that it was about 670 grams, which is a very large heart. Average human heart's like 330, 350 grams. So, a very large, thickened myocardium, can be predisposing to arrhythmias, potentially. So again, it's pure speculation on my part in terms of what happened to Rich, but this R on T phenomenon is a real thing. Prolonged QT is definitely a real thing, and we know, at least in the rat studies, high doses of nandrolone will prolong the QT interval. So, and if you already have a prolonged QT, which most people are completely unaware of, or you happen to be on a medication that's giving you a prolonged QT, and let's say you go out and decide to do large doses of nandrolone, theoretically that could be a problem, right? So anyway, FYI on that. This is some more information on the cardiac effects of nandrolone. This is the role of the renin-angiotensin system and the nandrolone decanoate-induced attenuation of the basal-gyrus reflex, which I hadn't heard about that in a very, very long time. This is from a 2011 article from the Canadian Journal of Physiology and Pharmacology. So I'm not going to get into the basal-gyrus reflex too much. It is a reflexive, like bradycardia, vasodilating process. It leads to hypotension in the setting of acute ischemia and sometimes acute reperfusion in inferior wall MIs. I saw it one time when I was out in the sticks and I gave thrombolytics to an inferior wall MI. Scared the crap out of me. Unfortunately, the patient did okay. But in this particular study, they not only looked at the effects of nandrolone on this reflex, which is actually a protective reflex in many cases. So nandrolone really blunted this protective beneficial reflex. So that's not necessarily a good thing. It may have led to, it may have been one of the reasons why those rats didn't do so well when they had their LADs tied off, is they didn't have this compensatory reflex, to potentially improve their odds of survival. But in this particular article, they also looked at rats, but they measured like prostate size. They looked at cardiac hypertrophy. They measured their mean arterial pressures, and that's what I want to talk about. That's why I think it's relevant here. And essentially what they found is is what you would expect, right? So they had marked departure from control groups in terms of left ventricular hypertrophy. So they developed enlarged hearts. They developed the equivalent of hypertension for rats, rat hypertension, okay? And they noticed a significant amount of cardiac remodeling. And not only that, but also an increase in these inflammatory markers, which I think may have been, part of the reason that they had this, unfavorable remodeling of their heart. So it upregulated like various inflammatory cytokines. It downregulated anti-inflammatory cytokines, and so overall, led to a situation where these hearts, where these rats did not have the healthiest cardiac function. Again, huge doses, 10 milligrams per kilogram for 8 weeks in these mice. Now, the interesting thing, they speculated that the renin-angiotensin system might be playing a role in this, because when they gave these rats, so they gave these rats enalapril, and all of these negative effects in terms of cardiac remodeling, inflammation, and elevated blood pressure, all were negated. So essentially returned back to what the placebo group was experiencing, which is pretty interesting. And I believe there's some other studies showing very, very similar things with angiotensin receptor blockers. And I think the one that they used in that case was losartan. So it would seem likely that whether you use an ACE inhibitor or an angiotensin receptor blocker, you can blunt some of these, deleterious cardiac effects if you're using high doses of nandrolone, and presumably like high doses, super physiologic doses of other, anabolic androgenic steroids as well. So now the lipid effects, not surprisingly, we all know that high doses of anabolic steroids are not great for your lipid profile. This is a study, the American Journal of Physiology and Endocrinology and Metabolism from 2002, metabolic effects of nandrolone decanoate and resistance training in men with HIV. So they just looked at lipid panels in men with HIV. This was kind of a weird protocol that they put these guys on, but again, much more nandrolone than is typically being prescribed today. So they started them on 200 milligrams. Second dose was 400 milligrams, and then for weeks 2 to 12 they were getting 600 milligrams a week, and then for weeks 13 to 16 they stepwise just went down, like 400, 200, 100, and then 50. Don't ask me why they did that. I have no idea. It seems like a weird protocol. Regardless, at least in this particular group of men, the deleterious lipid effects were not as profound as you might think. Total cholesterol, there wasn't a huge change. LDL, not a huge change in LDL. Lipoprotein A decreased, which, as you guys know from my other content, I've talked about the effects that androgens can have in lowering Lp(a), not only androgens but estradiol as well. Not surprisingly, fasting triglycerides decreased because you tend to improve insulin sensitivity when you're on testosterone and other androgens. So, but total HDL did go down. It was like, what did they say, 8.7 plus or minus 7.4. So at least in this particular study, it wasn't massive negative effects on the lipid panel, but the HDL did go down, the so-called good cholesterol, which, I hate that term, but, we're probably stuck with it for a while. It did have some modest reductions in HDL, so not as bad as you might think. The problem, of course, in the bodybuilding world is, Deca is rarely taken, or nandrolone is rarely taken alone. It's often stacked. It was in the 70s. It was apparently the old, the Deca and D-ball stack, and Dianabol, which is not legitimately manufactured, I don't think anymore. I think it comes exclusively from underground labs. I think, it's extremely liver toxic, extremely unfavorable to your lipid panel. So the combination of those two could potentially give you like extraordinarily poor LDL and extraordinarily poor HDL levels. So, not recommended. So, all right, guys, what has been my experience, and why the hell with all this stuff? Why would I even entertain the possibility of including nandrolone into my current protocol? Well, I'll tell you. So it's for chronic pain. So I have been very hard on my body over the years, and I'm not a smart man. I continue to be hard on my body, but as I get older, I am being forced to to rest more. I'm forced to be a lot more careful with injury, prevention, that sort of thing. But, this is a picture here I'll put up here. This is my lumbar spine. This is a year out from I had a minimally invasive L5-S1 fusion. I was suffering from severe chronic low back pain. This was a consequence of probably 10 years of heavy powerlifting, combined with jumping out of a vehicle with full kit and about a 60-pound rucksack on my back that finally pancaked my L5-S1 disc and led to a year of misery essentially before I finally bit the bullet and had surgery. But one thing you'll notice, those of you guys that are used to looking at films like this, is my fusion didn't take. I'm one of the rare people where, I did not get a good, strong, bony fusion here, so my back is held together by this hardware. So surprisingly, I had this done, in 2012. It's doing okay, but these screws are very painful. There is some movement in this area. And I continue to occasionally have radiculopathy and numbness and like a burning sensation in my foot. It's very, very uncomfortable. It keeps me up at night. I have had 2 very serious rotator cuff tears. I have a full thickness supraspinatus tear on the right that I suffered in my late 20s that continues to flare up and cause pain, not to the point where I needed to get, they recommended surgery. I said, no, thank you, and I just rehabbed it. I had an acute, massive rotator cuff tear and labral tear in my left shoulder doing jiu-jitsu a number of years ago that required a full repair and reconstruction. It was extremely painful. And that continues to be problematic for me. When my shoulders flare up, I cannot sleep at night. With both of them sore, I can't even pick a side. So it does affect my sleep. And on top of that, I have bilateral hip osteoarthritis. It's fairly severe in the right, to the point where my surgeon has said I'm going to need to have a hip replacement. My right knee, I've torn my ACL. I had a posterior lateral corner injury there too. I've had a near total meniscectomy, so I've got bone-on-bone arthritis in my right knee. I'm also in the docket for a knee replacement there. So all of these things add up to a lot of chronic pain. And, as I touched on before, those of you who've never experienced chronic pain is something that it really does. And I noticed this in myself before I had my back surgery. It really does change your mood. It changes your personality. It caused me to be just more short with the people that I cared about in my life, less empathetic to my patients, and it was miserable. And quite frankly, I'm very much against using opiates. So I've never used opiates at all. I never plan to. But I got to the point where I was using high doses of NSAIDs, mainly naproxen. And Vioxx. God, Vioxx worked great before they took it away from me. But I was having to do that every single day. And, there are significant risks and potential harms to NSAID use, which I can talk about at a later point. But I don't recommend chronic NSAID use. There's severe potential long-term complications involving the GI tract and the kidneys that I've seen, and I do continue to see firsthand in the emergency department. So I really wanted nothing to do with that. I try to be very sparing with it. Acetaminophen clearly is not good for your liver long-term either. So many days I kind of was just sucking it up. But I've known a long time from the gym bros about the effects of Nandrolone on joint pain. And so I had a discussion with my physician about it. And, honestly, I had pretty low expectations. But I thought, okay, why don't we give this a go? He put me on 50 milligrams twice a week. And I have since just switched to once a week without any, significant change in how I felt. But overall, I have to say I have probably at least had a 50% reduction in pain. So the quality of life improvement that I've experienced with this low-dose Nandrolone protocol, in addition to my normal 160 milligrams a week of testosterone, it's been profound. There have been days, especially with my hip, where carrying my infant son, I've had to go up the stairs backwards because I've had such severe pain in my hip. That's completely gone away. It's completely gone away. My shoulder pain has 90% gone away. So, in terms of how I feel every day, it's been really remarkable, and it's changed my mood. It's made me a much happier guy, and I'm a pretty happy guy at baseline. But at the same time, I'm aware of these potential deleterious effects, from a cardiac standpoint, and I certainly am not going to ignore them. So I've been meaning to do it this week. I'm going to go in for a full lipid panel. The orders are in the computer. I've just been so busy with shifts and stuff at home. I'm going to get a lipid panel done. I'm going to get an echo done here shortly. And then I've mentioned to you guys that, I plan in September for my 50th birthday, I'm going to go get a coronary CTA and take a look at my anatomy. And I will disclose all of that to you guys and let you know. My blood pressure has been unchanged. So it was just 119/60 on my home cuff this morning, which is typically where I live, typically in the 110s to 120s systolic. There's been no change there. My resting heart rate's 60 to 70, and I've noticed no change in that at all. I haven't had any fluid retention, no ED issues clearly with the testosterone in the background. So far this has been nothing but a positive experience, at least for me, in terms of overall quality of life. So that gets me to my next point. In terms of, whether I recommend Nandrolone for people, whether I think you guys should be using Nandrolone. So generally, no. Let me explain what I mean by that. So I think it's pretty obvious that, Nandrolone is not suitable for monotherapy for low testosterone hypogonadal symptoms. You need DHT, you need estradiol. Don't use it for that. I don't know of anybody that does. There may have been, in the past, but that's just not a good idea. It's substituting or just doing nothing but Nandrolone as your protocol. So, I think that goes without saying. You should not consider, and I certainly do not. I do not consider Nandrolone to be a longevity enhancing drug. Quite frankly, based on these studies, could potentially shorten your life, maybe. Certainly at high doses, I would be concerned about that. We just don't know with these low doses, but from an anti-aging or age management perspective, adding Nandrolone to your protocol there's no evidence whatsoever that will make you live any longer or make you healthier, in any sort of way, other than perhaps your mental health, because you won't be suffering from as much joint pain if that's the reason that you started on it. So in my opinion, the use case for Nandrolone is exclusively in the treatment of musculoskeletal pain, whether it's from osteoarthritis. Certainly, I think there's a use case for people that suffer from chronic pain and inflammatory arthritis, like rheumatoid arthritis, lupus, etc. There's good data in women and actually in men too in treating osteoporotic bone pain. It's highly effective for that. It works very well for the treatment of osteoporosis. It's right up there with bisphosphonates, but nobody ever talks about that. So within that little domain, I think there's a use case for Nandrolone. Outside of that, I don't think there's a use case for Nandrolone. There's just no evidence. If your goal is to be a bodybuilder, absolutely. If you want to get jacked and tanned, add some Nandrolone to your protocol. But that's not what I recommend. That's not what this channel is all about. So, outside of chronic pain, I don't really think that there's a good use case for Nandrolone. I would be extremely cautious if you are a man who has known coronary artery disease. I would be extremely cautious if you have a known prolonged QT interval. And if you don't know, just when you go to your doctor, ask for a 12-lead EKG. Get a baseline EKG. And I would be extremely cautious about any QT prolonging medications, of which, the list is so long I don't have time to go into it in here, but you can look that up online. Medications from multiple different classes, like I said, from antibiotics to antipsychotic and psychotropic meds. Methadone, if you're on methadone, that prolongs the QT interval. That's one I see quite a bit. So if you have any sort of, if you're prone to any cardiac dysrhythmias, if you have a prolonged QT, if you have known coronary artery disease, if you already have known left ventricular hypertrophy, if you have hypertension that is not adequately controlled, I think those are no-goes for Nandrolone as far as I'm concerned. And if you do decide to use it, I think the lowest effective dose is probably in your best interest. My plan is actually to go down to 50 and see how I do with that, because why would I take 100 when 50 does just as well? And honestly, if 50 does just as well, I'm going to go down to 25, and we'll see what happens. Because I can't deny that it has really made a major difference in how I feel on a day-to-day basis. But again, I'm not going to ignore these other potential deleterious effects. So if you're going to use it, again, lowest effective dose, and if you're not already, you need to be paying extra close attention to all of your other cardiac risk factors. So, all right, guys, I hope that I didn't go too long or too overboard with that. I hope you got some useful information out of this talk. So if you're using Nandrolone, I would love to hear from you. So, pros, cons, etc. If you have a different experience than I do, please let me know in the comments. I learn a lot from you guys. There's a lot of things in the medical literature, but I still learn a lot from patients and the things that they tell me. So I always appreciate the comments. So I will catch you guys next time.